So from neuro ultrasound, we'll move to cardiac sonography, but of course from intensivist viewpoint. So how does the intensivist approach differ when using ultrasound for cardiac assessment, and what specific insights does this perspective offer in critical care settings?
A very relevant question, Monalisa. We do echocardiography by the bedside, and we are also used to our echocardiography technicians perform echocardiography by the bedside. If you look at the way they do the scans, you will be struck by the kind of meticulous measurements that they perform, including the wall thickness, precise estimation of the diameters of the chambers, precise estimation of the ejection fraction. There are so many things which perhaps the critical care physician may not look at it through a microscope, which may not be all that relevant to us. So the question remains as to what are the things that you look for most essential to assess the hemodynamic status of your patient, and what are the parameters that are of most interest to the ICU clinician. First and foremost is the question in a shocked patient is, what kind of shock is it? Is it hypovolemic shock? Severe hypovolemia is usually very easy to tell just by eyeballing the four-chamber view. You will see the chambers are small, the walls may seem to approximate with each other, particularly the left ventricular free wall might approximate the septum if the ventricle is underfilled. There will obviously be a IVC which has a lower diameter than usual, which again suggests that the patient may be hypovolemic. So just by eyeballing the echocardiography, you will get a fair degree of understanding as to whether your patient is hypovolemic or not. Volume responsiveness is a different matter altogether. And for that, you need to go a little more in detail. And what I suggest to my trainees and what I often recommend them to do is to look at the volume responsiveness by measuring the velocity time integral from the apical 5-chamber view. You start with a baseline measurement, and then you do the passive leg raise. You do the passive leg raise, wait for a minute or so, and then measure the VTI again. And if this shows a change or an increase by 12 to 15% or more, it is strongly suggestive of volume responsiveness. It is relatively simple to do by the bedside, and it applies in patients who are ventilated versus patients who are spontaneously breathing. So it gives you an overall reasonably accurate picture of volume responsiveness. You need not measure the stroke volume, which involves measurement of the aortic diameter as well. You need not go into that detail. You just measure the VTI alone, baseline, and post-leg raise, and see if there is an increment in the velocity time integral, which suggests volume responsiveness. So VTI alone would do, and the respiratory swing on the VTI waveform would also be a strong, powerful indicator of volume responsiveness in patients who do not have spontaneous respiratory efforts. So that applies only to patients who don't have spontaneous breathing. The VTI variation with respiration, like with other respiratory parameters. But, as I mentioned, VTI pre and post passive leg raise would give you a good indication regarding volume responsiveness in patients who are spontaneously breathing, as well as those who are on controlled ventilation. Next, and most important, would be to look at the chambers, particularly the left ventricle. How is the left ventricular contractility? You don't need to have a precise measurement of the ejection fraction. You need not spend time to measure the left ventricular ejection fraction using the accurate methods that we know that our echocardiographers do by the bedside. Just eyeballing should suffice under most clinical circumstances to look at the overall LV function without having to estimate the precise ejection fraction. Right ventricular size and contractility is another important factor that you would look at, particularly in patients in whom you suspect a pulmonary embolism. There are many patients who might come to you as an emergency who may have hypoxia at baseline with normal lungs, wherein you strongly suspect PE. And in this situation, echocardiography can be a very easy to perform bedside tool. Just eyeballing to look at the ventricle size, the degree of dilatation of the ventricle, and its function. And we're all familiar with the McConnell sign, which is apical sparing when there is right ventricular dilatation in acute pulmonary embolism, although it is not specific for acute pulmonary embolism. So these are some of the features of acute pulmonary embolism by the bedside in a patient in whom you strongly suspect possible pulmonary embolism. They may be immobile, fractured limbs, and in bed, highly susceptible to a clot formation. The next most important thing that you would look for in a patient with shock is, does my patient have a significant pericardial effusion or pericardial tamponade? Very easy to visualize. Basic echocardiographic skills is all you need to look at the collection of fluid around the pericardium, and features of tamponade may be obvious, as in right-sided collapse in diastole. Both the right atrium and the right ventricle may collapse down in diastole, and that is a sure indicator that your patient is at high risk of tamponade or already in tamponade. One of the other things that I strongly suggest that we do is to look for intracardiac shunts in patients with severe hypoxia. For example, a patient with severe ARDS being ventilated with high ventilation pressures, high levels of P, but the hypoxia seems to be very refractory. Whatever you try to do, higher PEEP levels do not seem to reflect as in improvement of the oxygen levels. Is there a foramen ovale that is opened up? Could that be causing a right to left shunt? So the bubble test comes in very handy, extremely easy to do by the bedside, and it gives you conclusive evidence if there is a right to left shunt at all. A right to left shunt in case of an intracardiac shunt will appear within the first 3 cardiac cycles, but if it's because of hepatopulmonary syndrome, it will happen much later, after the first 3 cycles. So that's another important point that you look for when you look at a severely hypoxic patients. So these are briefly the very basic kind of assessment that you do by the bedside in the ICU, focused examination using echocardiography to assess the type of shock, volume responsiveness, look at the valves, see if there is any major change, mitral stenosis, aortic stenosis, all of which can cause severe hemodynamic compromise, size of the chambers, left ventricular size and function, RV size and function, pericardial effusion, and last but not the least, possible intracardiac shunt contributing to severe refractory hypoxemia.
Thank you, sir. I think I've summarized it pretty well. So, as sir said, mainly to differentiate different types of shock, to assess volume responsiveness, for which sir has told that we should use PLR, and to measure aortic VTI, and the respiratory swing in the VTI waveform as well in patients who do not have any spontaneous respiratory effort. Apart from that, looking at the LV and the RV contractibility size, and looking at pericardial effusion, And of course, the last thing, the intracardiac shunts. So these are the main things we need to concentrate on when we are looking at cardiac sonography from an intensivist point of view.